Welcome to this edition of Data at Breakfast. This morning, I'm very happy to introduce to you Professor Bruce Bassett. Bruce is, I think his main job is Professor of Applied Mathematics at the University of Cape Town, but he also heads the cosmology and machine learning department or activities at AIMS, also in Cape Town. Yeah? He also works as an astronomer at SAAO, yeah, and has been involved since probably just above a year in modeling COVID as part of the National Ventilator project. So we are very happy to have you with us this morning, Bruce. And in the panel at the top of your screen, you see also Professor Martin Bucher, who is also an astrophysicist, I guess, by training, but who also has been involved in COVID activities for obvious reasons since a year. Yeah, and Bruce and Martin and Ilya, in fact, are all heading a research program of NITEP. And although this is not a NITEP event, I will do a little bit of NITEP advertising. Yeah. And Ilya is with us as well this morning. As usual, he's the standard co-host of these online events. So Bruce, you're welcome to start sharing your screen and start your presentation. And while the screen comes up, a gentle reminder to the participants to use the Q&A facility to ask questions, or maybe to raise your hand if there are not too many interventions. Yeah, and yeah, and you know the rules of the game. So Bruce, thank you very much for being with us this morning. We appreciate very much your time and the effort to prepare a presentation for us. So you're welcome to start.
Thanks so much, Francesco. Right, let's get right into it. Projections for COVID in South Africa. Typically I'll write multiple blogs and put them on LinkedIn if you want more details. So where are we now in South Africa? This is a plot from Sugan Naidu on Twitter showing Eastern Cape, Western Cape, and Mpumalanga Northwest. And we see this characteristic second wave that has now plateaued. And we're now in this kind of holding pattern. You can see there are some indications of a small amount of increase recently. If we look at the other provinces, similar. Only KZN is going down, maybe Limpopo, but there's this, we've reached this kind of holding phase, which is in some ways similar to what happened in October last year at the end of the first wave. So it's a natural time to ask, well, what's next? We can look at excess mortality. We know that we are missing most COVID deaths. Maybe we're missing, we're missing most COVID deaths. I think that's unambiguous. Currently, we have had 151,000 excess deaths. So this curve is the average mortality, in this case for natural causes of people 60 years or plus. And then the dark blue is the actual excess mortality that we've seen. And we can see that we're still above the kind of normal ranges, and that has sort of plateaued. And there's a little bit of a difference. At the end of the first wave, we kind of came down to within the error bars of the normal range. We haven't done that yet. And so the natural questions are, is that going to continue to drop, or could this increase? We can drill down to provincial level on the excess mortality, and most provinces are still continuing to drop, but there are a couple of concerns. One is Free State, which has sort of started to rise, and the other one is, the only other one is KZN, where it's flat. So that again frames the question of what's going to happen next. So to start talking about predictions, we need a couple of key variables. One of them, is called R0, the other RT. So this is known as the reproductive number. Essentially, if R is either RT or R0, RT is simply this quantity over time. R0 is the value initially. If RT or R naught are bigger than 1, you see an increasing number of infections. If RT or R naught are below 1, you see declining. And so if we would look back at these numbers, over here, RT was bigger than 1. It was growing exponentially. Here, RT was lower than 1. And here, RT is around 1. We're roughly going static. And so that controls the future of the epidemic. The key thing is that RT is roughly, you can think of it as the probability of getting infected on average every time you interact with somebody times the average number of interactions that people have. So you can reduce RT, and this should be the number of interactions between people who are infected and susceptible. So you can get RT to be small if there are very few people who haven't been infected. That's what we would often call herd immunity. If there's no one left to infect, then the disease stops spreading. Alternatively, if you do a lockdown and people stop interacting with each other, that will also reduce RT. Or if everyone wears masks, for example, then they still might be interacting, but the probability of getting infected is lower. And so it's very hard to disentangle those three things. And that's a major challenge for us. So why is RT useful? Well, in the simple models that we often use, often called SEIR models or SIR models, there's a direct link between R naught or RT and the final fraction of the population that you would expect to be infected before the disease burns itself out. And you can see that relationship in this plot. You can see, for example, R naught of 2, you would predict something around, my eyes are not quite good, somewhere around 80%, maybe 75% of the population to be infected. If R naught is 3, instead you would expect somewhere around 90%. So knowing RT gives you an estimate of how many people would need to be infected. Strictly speaking, this curve is true for vaccinations, but is also potentially useful for immunity in the infections in the wild. It gives us a ballpark of how many people we would expect to be infected eventually. To illustrate the point about how RT is susceptible to social dynamics, really early, a year ago now, there was Imperial did an analysis of RT for Italy, showing that it started off somewhere around 3.5, and then through various social interventions, closing schools, self-isolation, social distancing, brought it down to around 1. So we know that social interventions are very powerful. One of the hard things and the bitter pills to swallow is that a country can be very disciplined, keep RT very low, and then relax after, for example, 2 years, and for that to make no difference to the final fatality rate. So over here, I've plotted simulations for 3 different scenarios where RT is initially 1.05, and then eventually transitions to an RT of 2. And you can see that in the first scenario, that transition occurs after 190 days, and you end up with here roughly 2, 3, 4, 5, about 500,000 deaths. In the second scenario, the transition to an RT of 2 occurs after 1 year. And in the other, the transition occurs after nearly 540 days. And you can see that the final fatality rate in all of them is essentially identical. So this is the key thing about why it's so difficult to talk about future fatalities, is that unless you know for sure that fatalities, that the reduction in RT is caused by herd immunity and not by social behavior, it's very difficult to know whether you will end up in this model or in this model. So that's the question for South Africa is, did the second wave end because of changes in social behavior, people not going out, people wearing masks, or was it a true herd immunity where the majority of the population were infected and 80% of the population has been infected and it actually wasn't driven by social dynamics? So as an example of how this plays out, Poland, you can see that Poland's cases had Poland essentially had no first wave. May, June, July, August, September, nothing. This was all the time when America and Italy and France were really having terrible losses. They had no first wave at all. And then in October, they had a massive first wave when other countries were having their second wave. So this is, I just thrown to illustrate how difficult it is to predict the future course of the disease. Similarly, Belgium was one of the worst hits in the world in terms of deaths. They had a bad first wave, a bad second wave. And ever since then, which is, the 1st of December roughly was the end of their second wave, they've just been mulling along at about an R of 1. And then just in the last month, there is some evidence of increase again. RT becoming bigger than 1 again. So just a quick comment on how deadly COVID is. It's very difficult to estimate the fatality rate from COVID because we miss most infections. We miss many deaths, as we showed in South Africa. So we're interested in the so-called infection fatality rate. What's the probability of a person dying given that they get infected? We can get a lower bound. In other words, we can establish that the infection fatality rate is larger than a certain amount by simply assuming that everybody in a population has been infected and then looking at how many people died. And so if we do that, for example, if we take the New York State and New Jersey in America, that gives us a population of 30 million people. They've had about 74,000 confirmed deaths. And that tells us that the infection fatality rate has to be at least 0.26%, which means it's about 260% higher than bad flu. We know it's almost certainly significantly higher than that because, we know that not everyone has been infected. If we apply the same idea to South Africa, we get that the IFR in South Africa is bigger than 0.27% if we use the excess mortality figures of 150,000 deaths so far. Of course, this number can easily change if we get mutations that are more deadly. And in Brazil, what they're seeing is that the ICU are filled with much younger people than used to be. And that's particularly bad for Africa because in some sense, Africa has been somewhat spared. And one of the arguments for that is that South Africa has a very young population. So if we see mutations that affect younger people, this could be catastrophic for Africa. So how do we make projections? Well, the approach that we took nearly a year ago, actually, in doing our form is to say we can't predict how RT will vary with time. Nobody knows that because it depends on things like climate, masks, how much people comply to lockdown, contact tracing, quarantine, government policy, multiple strains. So what we did instead is that we simulated thousands of different curves, which in some sense mimic all of the possible behavior that we think could be possible. And for each one of these, we can therefore make a prediction, and that's what we did. And so we ended up with, in this case, 2,000 possible future curves. And what we see here is total cases in the bottom right, hospital people requiring hospital. Of course, it goes up to, several 100,000 people in the peak models. There's no way that South Africa could handle that number. So this is not the number of people in hospital. This is the number of people who would ideally require hospital treatment, the number of people in critical state, and then finally the number of fatalities. And you can see that our predictions ran from a few thousand down here to several 100,000 fatalities. And the median is this white curve that ended up at about 160,000 deaths by the 1st of April 2021. So these are days. And you can see that the black line was the initial data. So where are we now? Well, here's the same plot, but with the official deaths in the dashed line and the excess mortality in the solid line. And this was up to a couple of weeks ago. So we can see that, the median curve actually tracks the excess mortality pretty well so far. And that's not surprising for statistical reasons. But of course, this goes to the, here, the end of this curve is the 1st of April, 2021. So we are now somewhere over here, slightly above this, but actually very close to this white line still. The white line was about 160,000 final. So of course, the question is, well, what's next? What's going to happen for the rest of the year? Well, to try and answer that question, you can ask, what are the key factors? So the first one is the one that I raised earlier. Have we reached herd immunity? As in, have 80%, say, or 70% of South Africans been infected? And therefore, actually, it was simply that we've run out of susceptible people? Or did the second wave end primarily because of social behavior? People starting to wear masks again, stopping to socialize. And it's very hard to tell the difference. My personal gut, if I had to express, is that it's probably a combination of the two. Serology, so blood tests suggest that somewhere between 50 and 60% of South Africans have antibodies. So 50 to 60% is less than 80% or 90%. But those predictions of 80 or 90% herd immunity as the final attack rate are based on very simple models. So it's possible that the herd immunity scale is actually significantly lower. But at the same time, the second wave ended a few weeks after the end of Christmas when everyone was socializing. So it could be either. So we don't know yet. Second big question is, why did South Africa create such a virulent variant of concern, VOC, which evades? So subsequent studies have shown that the so-called South African variant, the variant that emerged in our second wave, probably reinfected a large number of people who had been infected previously with the original variant of COVID. So the question is, why did South Africa lead to the one that was so effective at evading the immune system? And the reason that's important is, could South Africa become a factory for these kind of new variants that evade the immune system? Perhaps because we have a large population of HIV patients or tuberculosis patients. Will new variants of concern also evade the immune system and cause reinfections? Like they did in the second phase? I mean, that I think is essentially the key question. And then a related one is, how often will these variants of concern arise? Back in the old days, I think there was a hope that these mutations would be pretty slow. And in some sense they are, but at the same point, variants that are more transmissible and escape the immune system seem to be arising surprisingly often. So I think there's some big questions around that. So let's look at some of the scenarios. And the best case scenario is that we have no more waves. That would be the best case scenario for us. For that to be true, I think we need the following all to be true. So for the best case, we need all of the following to be true. First one is that we reached herd immunity and the second wave ended because of essentially herd immunity due to, so, a large fraction of the population is infected and there just are no more, there's just a very small number of susceptible people left. In other words, it wasn't because of a lockdown of people stopping to socialize that ended. Because the problem is if it was due to social dynamics, then as soon as people start socializing again, and we have Easter coming up, we have school, etc. If it's due to social dynamics, then we'll get another wave as soon as the socialization, as people relax. And it seems, based on worldwide things, that people can sort of handle proper social distancing for about 3 months. And after 3 months, deaths drop, people relax, and then we get another wave. I see there was a question. I'm very happy to answer questions as we go along. I can't see the chat, so I don't know, Francesco or Ilya, could you maybe just tell me if there was a question?
Yes, Bruce.
In fact,
sorry.
Yeah, in
No,
fact, there is a question Q&A, but there is also a couple of questions in the chat. So are you happy to take 3 questions?
Yes, please.
Okay, let's start with the Q&A. So Q&A question is, what happens in Manaus with the new infections? They were supposedly at 70% herd immunity before that.
Great. Yeah, exactly. That I will come to the P1 variant a little bit later, but that is exactly the concern. So there's a couple of possible explanations. One is that their estimate of 78% or 76% infections was wrong. Often these are based on small samples, a few hundred people, and so you could just be unlucky, and you might, there could be large error bars. That's the one possibility. The second possibility is simply that the new variant evades the immune system, like appears to be the case with the South African variant. And so you had a lot of people being infected, 78%, but then the new variant came along. In some sense, if you are infected with one disease, it doesn't usually give you any immunity against another disease. So if the variant is sufficiently different, it may not give any protection. So we don't know. But I think the most likely is that the new variant just evaded the antibodies and the T cells from the previous variant. Of course, just because you get reinfected doesn't mean that you are as severely infected. So it may be that you still get infected and still can infect other people, but you yourself only experience mild or asymptomatic symptoms. So there's a whole continuum of possibilities.
Okay, thank you. Okay, let me go to the questions in the chat. And in the chat, we have a couple of questions. I think the first one you partially covered. So it is, hi, Bruce. Are you implying that once infected, you are immune to the second infection? So I think
So the answer is no, you are not. There's no immune. Even with the original variant, there was a question about how long your antibodies would last. There were some people whose antibodies dropped quite quickly and therefore could get reinfected. But now, with the variants of concern, it's definitely a possibility that you can be reinfected.
Okay. And another question in the chat is, how much do we need to know about the comorbidity factors statistically? It would be interesting to show some valorizations, divided bar graph of other cases of death with COVID-19 deaths.
Yes, I can probably show. I mean, it's very. Let me just jump ahead. I haven't seen any really recent analyses, but we did have this in the early days from the Western Cape. So this is percentage of deceased patients with a given comorbidity, and you can see here chronic kidney disease, hypertension, cancer, cardiac disease, obesity, and TB, HIV, asthma. And this is split by age. So this was a wonderful thing. And you can see that, for example, hypertension, the yellow, was actually a major cause of death among people above 50 years. HIV, which is the red one, was quite common in younger people, wasn't a major cause in. But of course, with this was in the first wave. I haven't seen a version of this for the second wave, and we don't know what this would be for example, the P1 variant or the UK variant. So yeah, limited information.
Okay, and I think there is one more question in Q&A, and I think we need to continue with the talk because you might also reflect this question later in your talk. We are currently rolling out vaccination. How much difference will it make in your scenarios?
Yes, so in fact, a key factor that I didn't write down is to what extent will future variants and even current variants be able to evade the immune boost from vaccines? We don't know. We know that some of the vaccines don't really help very much against the South African variant. Some of them really do well. Moderna and Pfizer, I think, do pretty well, and and we know that it's possible to update those vaccines quite quickly to provide immunity against the new variants. The concern for South Africa is, will we ever be able to get access to those vaccines? And if we are the ones who are creating the new variants, because, for example, whatever reasons, then we will, we will create the new variants, and then it will take time for the world to create the vaccines that protect against those variants. And so we will always be getting the worst of it. So yeah, those are big open questions. Unfortunately, we don't have answers. So yeah, let me jump in, carry on where we were. So let's look at some scenarios. So basically what I'm saying is we have no way of making projections. It's very, very difficult. So rather, let's look at scenarios. One scenario, the best case scenario, is that we have no more waves. For this to be true, we need to have reached herd immunity due to infections, not social dynamics. We then need that the resulting immunity, the antibodies and T cells, are robust against all new mutations. That is potentially possible. We also need that the protection from that immunity lasts until we get large-scale vaccinations. So large-scale, at the rate we're going currently, it'll take us 10 years roughly to vaccinate a significant proportion of the population. So the two factors above could be true, but if the protection only lasts for 1 year and it takes us 5 years to vaccinate everyone, this isn't going to protect us. We also need that no new variant emerges with a significantly higher RT. So for example, if we go back to this plot, sorry, this is a bit inefficient. Let's imagine that the South African variant had an R naught of 2, so that we need herd immunity. The final attack rate is the final percentage of population who would be infected. Let's say it was 2.2, then we needed 84% of people to be infected to end that would be the final number. But let's say a new variant comes along that has an R of 3, suddenly we're up above 90%. So even though the people who've been infected are protected, we might still get a third wave, although somewhat smaller, just because the new variant has a higher R value, even though it's not actually reinfecting new people, people who were previously infected rather. So the reason I bring that up is that the P1 variant from Brazil appears, initial studies suggest it's significantly more transmissible. So if we look at Brazil, we see just now that right now, apparently 60% of all ICU patients are under the age of 50, which is very, very, very concerning. It's concerning for the world, it's concerning for Africa, and it's very concerning for South Africa. And in particular, we see this, their deaths are just going straight up. So it's concerning. And when there's been an initial analysis of the relative transmissibility of the P1 variant relative to the old variant, and in this paper, they estimated that it was 250% more transmissible, which is terrifying, right? If it's accurate, because the so-called South African and UK variants were between 30 and 80% more transmissible estimates. It's very difficult to estimate these transmissibilities, so you have to take this with a large grain of salt. The uncertainty on this number will be very large, but just the mere fact that this comes out as a reasonable estimate is very concerning. Yeah. So in particular, if this really is true, you would expect the fraction of younger people in ICU to grow very rapidly, simply because they would prioritize young people in ICU, just like we do in South Africa. When the ICUs are full, they give priority to the people with the best chance of surviving. So it doesn't necessarily mean that the virus is more, that younger people are more susceptible to it, but it also doesn't not mean that, right? So I see there was another question.
Yes, if you want to take it, I'm happy to read
Sure.
it. In terms of SA variant, there are theories that it is not created in SA, but was rather first detected and sequenced in by South Africans, but could have originated in other places. Are you saying that it was in fact created in SA?
No. I mean, none of these variants, we can't be sure that where any of these variants come from, right? Absolutely. Could come from anywhere. It's because, however, there is an argument with these variants that are much more transmissible than the other variants. Let's say that the variant actually started in country X and was brought to South Africa. That means that the variant was spreading first in country X, and you would therefore expect it to dominate first in country X. It's a bit unnatural that it started in country X, for some reason didn't spread there, but was brought to South Africa and then did explode in South Africa. It's possible. It's just not the most likely scenario. The simplest scenario is that it was created. There certainly are cases. We certainly cannot say that it definitely arose in South Africa. That's true. It's the simplest explanation, but probably once you have enough of these variants circulating, probably at least one of them actually originated somewhere else. And certainly in South Africa, we were very quick to sequence data. South Africa did very well at sequencing the data very quickly and discovering this new variant. So it could well have emerged somewhere else. So yeah. So let me move on. So this is of course very concerning. So what about, so we discussed the best case scenario where basically we're done. There'll be no more waves, but we saw that it required several different factors to be true for that to be true. Well, what's the worst case scenario? The worst case scenario is that we're going to face 2 waves every year for the foreseeable future, next 5 years. That I think would be the worst case scenario. How would that scenario emerge? First, I think it would be driven by variants of concern, and that these variants of concern would have to arise quickly. And these variants of concerns would have to be able to evade vaccinations and the immune system of people who've been previously infected. So in other words, like with flu and with cold, you're just susceptible to getting infected every year. And one point that, for this to be really an issue of concern is that it would have to maintain its lethality. So in other words, having previous infection, you know, it would need to be that you would still get seriously sick. And there is a route to that I've always worried about, which is that we know that even asymptomatic and mild COVID causes cardiac damage, you know, damage to the heart. We know that some fraction, 10 to 20 to 30% of people experience so-called long COVID, where they are struggle with the kind of post-viral fatigue, etc. And so, you know, if those people have weakened immune systems, it could be that reinfections are serious. It could be that the lethality of these future variants of concern are particularly bad for people with HIV or TB. You know, so then it would be perhaps not so bad for most of South Africa, but you know, we have 8 million, I think, HIV patients, people living with HIV. So, you know, if the lethality of the disease towards HIV increased significantly, that would be very bad. So if these are true, we could be facing, you know, 150,000 deaths a year, potentially more if it becomes more lethal. You know, the P1 variant, we don't know if it's more lethal. The UK variant estimates were that it was more dangerous. It could be that on average, the lethality doesn't change, but it suddenly becomes more dangerous to young people, while simultaneously becoming less dangerous for old people. That would be deadly in South Africa because most of our population is young. I mean, I think I've got let's just have a quick look here. Here's the demographic chart for women in the Netherlands in orange and women in South Africa. And you can see that the Netherlands has this big hump above 60 years, which is completely missing in South Africa. I think only, actually, I can't remember the exact number, 5%, a very small percentage of South Africans are actually over the age of 65. Most of our population is young, and that's true for Africa. You know, a large fraction of Africans are under the age of 40. So if the disease becomes more lethal towards younger people, that would be very, very bad. There's another, you know, we can consider, of course, multiple scenarios in between the best and the worst case scenario. One of the bad things particularly about the P1 variant is that when you have a more transmissible disease, the waves happen much faster. So they kind of smack into the population and then they go quicker. So we can sort of see that actually, if we go right back to the excess mortality data, you can see that our second wave obviously was higher, but it was also more peaked. You know, the base, you know, it went up and came down faster. And that's typical if you have a more transmissible disease. That's very bad for us, and it's very bad for anyone, because it means that you get a large number of people needing hospital at exactly the same time. And so, for example, in our simulations, we modeled the effects of ICU overwhelm. In other words, if you run out of ICU beds. And this was the histogram of the infection fatality rate from all of our 2000 simulations. The black is where you say, no, I've got an infinite number of ICU beds, versus in red when we modeled the South African capability. And what we see is that, you know, it had a major impact on the number of deaths. I can't remember what it was on average, but let's say 30, 40, 50% increased fatalities. So if the Brazilian variant comes in and it really is 2.5 times more transmissible, you run out of ICU beds very quickly, and this effect becomes much more pronounced. And in fact, that's what we're seeing in Brazil. I think essentially every state in Brazil has more than 80% or 90% occupancy of the ICU. And that means, you know, lots of people just dying because there's no hospital. So that's another very bad factor for us. So I would say you know, worst case is that we have 150,000 people a year dying from COVID for the next 2, 3, 4, 5 years. You might think this is unthinkable, but this is exactly what happened with HIV for 10 years. We had over 100,000 deaths a year from HIV. Intermediate scenarios, we can easily construct intermediate scenarios where there's 2 more waves, where the South African variant, so-called, does provide good immunity to future variants of concern, but the second wave ended because of social dynamics, not because of herd immunity. And therefore we will have another wave in, you know, in May or June or even April, but that at that point we reach herd immunity. Or maybe we have 2 more waves and then we reach herd immunity. Or perhaps the variants of concern can partially evade the immune system, so that 50% of people who have been previously infected become reinfected. So we get these kind of rolling small waves. So really, I mean, unfortunately, we really just don't know. So I think I'll jump to summary because I hope there are more questions. So I think the main thing is, you know, we basically cannot make any predictions with any accuracy at this stage. It's always been very uncertain, and it remains very uncertain because although we now know a lot about the original variant of SARS-CoV-2, there's all these new variants emerging. I see that India now has a variant of concern. And so India has taken a decision to ban all exports of their locally manufactured vaccines. So I think, you know, there's a political dimension to this that we haven't, that's only just beginning to play out, which is vaccine nationalism. So the key issues are, did the second wave end because of social dynamics of people behavior, or was it herd immunity? Does the South African variant, as we call it, we shouldn't call it the South African variant, but you know, giving its genetic designation doesn't help for most people to understand what we're talking about. So does that provide good immunity to reinfection from all new variants of concern or not? Will vaccines provide immunity to future variants of concern, and will we be able to get access to them? You know, big questions there. And will South Africa be a continuing source of new variants of concern? You know, I think there was a case in Boston where they saw a man who never cleared the infection. He had the virus in his body for multiple months, and they saw him generating new mutations. If our HIV patients, for example, our population of HIV sufferers are like that, we could be the source of many new variants of concern, and essentially incubating variants that evade the immune system. You know, we just don't know. So I think I'll stop there. Take any other questions.
Yeah, thank you very much, Bruce, for a very sensible and sober account of future scenarios of the current pandemic. We had a few questions already, but I'm sure Ilya and Martin will guide us to the following questions. Yeah.
Okay, yeah, there are a few more questions in Q&A, so let me start. Has any modeling been done on ivermectin running parallel with the vaccine rollout? Should it prove to be effective?
No, and I think well, I'm not aware of it, and I think the reason is that we just don't have good data on the effect it could have. The uncertainties that we have are so large already that a small 20 or 30 or 40% effect, you know, is very small, unfortunately.
Okay, okay. So the next question is, perhaps tell us more, how do you think vaccination or advances in treatment may influence the dynamics?
I hope I covered that somewhat. I think there are definitely, Moderna and Pfizer and others are trying, of course, to build vaccines that will work for all variants of concern. So it's a kind of it's like a competition, right? It's literally a competition between the humans trying to generate general vaccines and the vaccine and the virus on its side trying to evade that. We don't know which one will win, and maybe Martin can say something about that. I think it's early days. I think I have a lot of faith in humanity's ingenuity. I don't have so much faith in politics and whether we will get access to those vaccines in large numbers in a timely fashion.
Okay, thank you. So the next question is, it would be very interesting to see the breakdown of having a COVID by demographics. Has it been done? The same applies to the breakdown by genetics.
Yeah, so I don't know about genetic analysis. I mean, people were looking for whether genetics has an effect on severity, probability of death, etc. In terms of demographics, I meant to put that slide in, but forgot. There has been a study in South Africa which looked at amount of antibodies, so serology by race in several provinces of South Africa. And I think, might be wrong, but I think on average it was about 20% of the white people that they tested had antibodies, and going up to about 60% in Black communities and with other communities in between. So obviously that confounds also wealth. So it may be that it's more of a middle class issue. I think it's probably, based, are you living in a house by yourself? Are you able to work from home? Those sorts of factors.
Okay, okay, thank you. So the next question is there potentially a case where people who are vaccinated can get infected, not get sick, but still pass the infection to others?
Absolutely. That's a big question. And that one's very hard to answer. So it absolutely could be that you are asymptomatic, but then simply transmit it to other people. I think the evidence for AstraZeneca was weak. It did not seem to provide protection from passing it on, but perhaps with Moderna and Pfizer, it looked more promising that it would stop the infection. But I haven't followed that very recently, so there may be some new insights, but it's definitely an open question.
Okay, okay. So let me ask a question from the chat. If the chance is very low that a significant number of people will get vaccinated, would it be prudent to encourage people to have a normal flu vaccine?
So I think having the normal flu vaccine is generally recommended. I mean, this is now getting into medical advice, so I'm not a medical person, so take this with a big dose of salt. The usual advice is get vaccinated with the flu because you see, if you get sick, it causes you a lot of stress, right? Have I got COVID? You then go to the medical facility to get tested. Medical facility is a place that you might get infected with COVID. So I think the general argument is yes, get vaccinated for flu. That's the general advice, yes.
Okay, okay. So there are a couple of more questions in Q&A. So the idea of long-term shedding of the RNA of the virus, could this be potentially ineffective RNA and not just detritus as we currently think? Could this be why there is so much transmissibility?
I'm not sure I understand the question. If the question is, the usual argument is that after a few days, people are not actually infected, but they can still show fragments of RNA that the test can pick up. And so I don't think I shouldn't comment because I'm not a virologist. I can tell you what I understand other people to have meant. That, in other words, I don't think that that's an issue, but yeah, it's not my field. So I think it's important for me not to speak on things I don't actually understand.
Okay, thank you. And could you please differentiate between a variant versus a variant of concern?
Yeah, sure. I mean, maybe Martin can say something on this. Mutations are happening all the time. So there's gazillions of mutations. Most of them do nothing, right? It's like if you cut your hair or not, it doesn't change who you are. If you lose an arm, that's a mutation of concern. So some of the mutations, manifestly change either how transmissible the virus is or how dangerous it is. And that's a variant of concern, is one that appears like it might be more transmissible or more dangerous.
Okay, I don't see any more questions in the Q&A, so I hand it to Francesco.
Yeah, no, thank you, Ilya. I know, Martin, you were put on the spot. I don't know if you would like to comment as well.
Well, I think that's a good question. There are so many different mutations, and I think the other point that is sort of interesting is, I mean, South Africa is pretty high on the list in terms of countries that do a lot of, genetic sequences of positive cases. I guess the UK has been the lead in this, but there might be a lot of variants elsewhere in the world that aren't being picked up yet because the data is very concentrated in certain countries. I also had a question, maybe you could react to this, but that's maybe more political. So you mentioned that in the worst case scenario, all these variants might, come back and prolong and make much worse the epidemic. But there's another issue in parallel, as sort of the rich countries saying, well, let's just vaccinate ourselves first. And if these new variants are become the major concern, then perhaps there would be more incentive to share and put more resources into, vaccinating the rest of the world and testing, doing testing where variants occur, rather than, just the rich countries worrying about themselves and forgetting about the rest of the world, except for some nice rhetoric. So I was wondering what your thoughts on that might be.
Yes, I think if we got the world's epidemiologists together and asked them to devise a vaccination strategy for the world, we would end up with something very different from what we are likely to actually see. For example, a natural thing to do would be to try to shut down all the factories of new variants worldwide. And if that is indeed people with compromised immune systems, then what you would do is you'd say, okay, sure, we want to vaccinate healthcare workers. Everybody's doing that, great. But now let's vaccinate everybody who may be the source of new variants of concern. So, South Africa, you've got 8 million HIV patients, for example. Great, let's vaccinate, you as part of the first wave. So try to shut down the source of new variants. I think that would probably be the optimal thing for the world, because the danger for the first world is they spend a lot of money vaccinating the entire population, and then a new variant emerges that doesn't protect them at all. And so what I suspect will happen is that first world countries will try to vaccinate everything and then simply try to block, put up walls to stop these new variants from coming in. But I think that's very, very hard, right? Worst case scenario, they say, oh, South Africa is a problem country. They are the ones who are creating these new variants. Meanwhile, it's just because we're doing the sequencing, like you mentioned, whereas other countries just are keeping quiet and not doing any sequencing. And then they say, sorry, not only can South Africans not travel to America, for example, but Americans can't go to South Africa because they may bring it back. So in the worst case, you could see a kind of very, very strong nationalism appear. But, I'm not a politician and I'm not a political scientist, so these are pure speculation, and I'm not sure it's worth very much. So just a caveat.
Okay, there is a question in the Q&A which just appeared, and I think it's quite interesting one, so you might answer it. We're planning a conference at the end of July. We need to know whether to plan for the virtual event or live event. Any advice? Would we be in between the waves?
July, so it's middle of winter. So we did a little bit of analysis. I didn't talk about this, but we did a statistical analysis of what were the factors that affect the spread of the disease. And this won't mean a lot, I think, but we did find that colder weather and colder and wetter conditions favored the transmission of the disease. So depending on where you are, like in Joburg, prediction was that winter would be the worst. So colder and drier promoted the transmission of the disease. It wasn't very, very strong effect, but it does mean that in Johannesburg and Gauteng, for example, winter is expected to be worse. But, at this stage, who knows? Really, I have no advice. I would say, if we go back to the original South African data, as a Bayesian, I'm a Bayesian statistician, so I would say let's use the past data as the best indicator for the future. So if we use this, then it appears that, there's probably 2 to 3 months between waves. So if we add 3 months to now, you get April, so we get end of April, end of May, end of June. So unfortunately, July would naively be sort of when we would expect the new wave to be coming, very naively. And the problem is, if we look at this, it took 2 weeks or 3 weeks to go from, things are not so bad, to, it's clearly that we're in a new wave. So even 6 weeks before your conference, you might say, things are looking pretty good. And then 3 weeks later, it could be obvious that the third wave is on us. The problem is, June-ish is around the time of school holidays. So I think it would be pretty brave to arrange it for in-person. And so, yeah, but that's just me. I'm naturally conservative. So my own conferences, I'm not planning anything in person this year, but that's just me.
And it's also me. We'll keep doing the data breakfast online for quite a while, I guess. Yeah. Okay, Ilya, are there further questions? Because I see we are reaching our natural time limit. I see there are 2 raised hands. Maybe let's allow them to quickly to ask their question live, but under the condition that they do it quickly, because I know from experience that after 8:30 people start leaving, and it's already the case. So please, Isabel, if you would like to quickly ask your question, and Bruce, if you would kindly quickly answer. Yeah. Isabel, please, you should be allowed to talk. You just unmute yourself. Okay, I think Isabel is not answered. Let's try with Sylvester. Sylvester, would you like to ask a question?
Hi, good morning, everyone. No, thank you so much. I think this webinar has been very, very insightful. Thanks again.
Okay. Okay, Bruce, that was just compliments for the speaker. So thank you very much, Sylvester, for that. Yeah. So Bruce, then you see the audience insisted to thank you in person. So a big thank you from myself and from all of us for a really very informative and really down to earth talk that will give us some food for thoughts. Yeah. And I hope that, as you say, that some politicians might listen to this talk as well, because they might also get some insight for what they will decide to do with us in the near future. A big thank you also to Martin and Ilya for their constant support, and we will see you again. I think in 2 weeks, because next week I think it's a public holiday, if I remember correctly. Yeah, but you will see the announcements in due course. So thank you very much, Bruce, for a fantastic talk, and I hope that on the time scale of the next wave, we will be able to invite you again to give us an update on the scenarios then. Maybe reporting on the positive effect of lots of vaccinations. Yeah, that hopefully will happen very soon.
That would be great.
Thank you very much. You all have a good day, and keep being safe and following all the standard procedures for the pandemic. Yeah. So thank you very much. No conferences live. Yeah.
Thanks very much.
All the best. Have a good day.
Yeah, thanks, Bruce.
And a nice weekend. Bye-bye. Cheers.